For many practitioners, fitting a patient with keratoconus is a time-consuming and frustrating undertaking. Irregular corneal topography, a wide range of severity, and a variable rate of progression present the practitioner with unique fitting requirements in each case. A poorly fitting lens can cause considerable damage to the cornea and may result in significant scarring and loss of visual acuity. An optimum fitting minimizes the risk of lens-related tissue damage. Successful RGP lens fitting for keratoconus requires an extensive range of trial lenses that are suited to mild, moderate, or advanced cases. A golden rule for the keratoconic eye is that the best fitting trial lens must be as close as possible in design and power to the ordered lens. The rose case system is designed to achieve a high percentage of first-time successful fittings at any stage in the progression of the disease. There are a number of key design features in the rose case system. These include an extensive range of back optic zone radii, smaller back optic zone diameters as the radius steepens, simplified edge lift control to facilitate ordering, and significantly increased lens power as the radius decreases when fitting advanced cases. These unique design features guarantee a high success rate when fitting the potentially difficult keratoconic patient. Lens selection. Selection of the trial lens radius is usually based on corneal topographical mapping or keratometry results. For this patient, the keratometry values are 7.2 at 170 and 6.0 at 90, giving a mean K of 6.6 millimeters. The recommended radius for the first trial fitting lens is 0.2 steeper than the mean K. In this case, a 6.4 millimeter lens is fitted and evaluated. If a corneal topographer is used, the trial lens radius is dictated by the corneal curvature at the third ring on the horizontal meridian in the temporal quadrant. Lens application. Trial fitting lenses may be stored dry or wet. Dry lenses need to be lightly cleaned, rinsed and then wetted with a conditioning or wetting agent prior to application. This prevents the problem of non-wetting patches on the front surface of the lens, which may hinder the fitting assessment. Lens assessment. The key fitting characteristics that must be assessed and optimized are the central fitting, peripheral fitting, the total diameter, lens location, and the amount of lens movement. Trial lens fitting. The extensive Rose K trial lens set enables even a novice practitioner to confidently fit their keratoconus patients. A short-acting, topical corneal anesthetic should be used prior to lens application on new patients. This will maximize initial comfort, reduce tearing, and optimize assessment of the fluorescent fitting pattern. After application of the lens, have the patient gently wipe away any excess tears. Then apply a small amount of sodium fluorescent on the conjunctiva and have the patient blink a few times. Accurate assessment of the fluorescent pattern is crucial for successful fitting of the Rose K lens. If an excessive amount of fluorescent is applied, evaluation of the lens to cornea fitting relationship is more difficult due to the thick layer on the front surface. Central fitting. The fitting pattern should be assessed when the lens is concentric with the limbus. The pattern observed when the lens is descented can be very misleading and may result in the selection of an inappropriate back optic zone radius. In most cases, the lens must be positioned centrally by using the lids. A combination of gentle pressure on the lens edge from the lower lid margin and raising of the upper lid will center the lens on the cornea for accurate and consistent assessment of the fluorescing pattern. The central fitting characteristics on a keratoconic eye are very important as they determine the physical and physiological performance of the lens. Begin by analyzing the central post-lens fluorescent pattern. If the pattern shows excessive pooling, then fit a flatter radius to achieve light or feather touch on the apex of the cone. Heavy bearing centrally must be prevented by fitting a lens with a steeper radius. Any signs of apical staining during wear indicate the need for a steeper back optic zone radius to reduce the pressure on the cone apex and minimize the risk of corneal scarring. Peripheral fitting. Once the best radius is determined, the next step is to analyze the peripheral fitting pattern. The degree of edge width and lift must be optimized to allow for adequate lens movement and to provide for a free exchange of tears behind the lens. The Rose K standard edge lift design will be acceptable for about 70% of eyes and produce a fluorescein edge width of 0.5 to 0.7 millimeters along the horizontal meridian. Due to unequal peripheral corneal flattening, the edge width may be very different in the nasal and temporal quadrants. In about 20% of fittings, the standard edge lift design will be too tight, producing inadequate width, reduced lens movement, and inferior decentration. This is typically observed with steep, nipple-shaped cones. In such cases, an increased edge lift should be ordered to improve movement and centration. 1 in 10 trial fittings will show an excessively loose edge with too much width and clearance. For these eyes, a decreased edge lift is required. Total diameter. An optimum lens diameter promotes centration and stability in the fitting. The 8.7 mm diameter is most commonly used. As the cone steepens and becomes more nipple-shaped, a smaller diameter may be required. The palpebral aperture size also dictates the appropriate lens diameter. The aim is to fit the lens so that the upper lid margin and lens edge are just touching. If a larger overall diameter is fitted, this will generally cause the lens to ride higher on the cornea. Lens location. Many RGP lenses on keratoconic eyes will decenter inferiorly. This is particularly true for the novice wearer due to excess tearing. Acceptable mislocation will see the lens edge on or inside the limbal zone. Excessive decentration beyond the limbus will usually cause discomfort and visual problems such as flare and ghost images. To improve centration when a lens is resting inferiorly, the radius can be flattened, the total diameter made larger, and the edge lift can be increased. Lens movement. A key factor in successful RGP fitting for keratoconus is the quality of lens movement. With each blink, the lens should move freely across the cornea and then return to its position of rest. Limited movement may result in peripheral corneal desiccation, a build-up of post-lens debris, and possible lens adherence. To improve lens movement, the radius can be flattened, the total diameter made smaller, and the edge lift can be increased. Visual assessment. After determining the best-fitting Rose K trial lens, a spherical over-refraction is performed to evaluate visual performance. Begin by using plus and minus 1 diopter steps and then fine-tune in half or quarter diopter steps. If unsatisfactory vision is obtained with a spherical lens, then perform a spherocylindrical assessment. The power of the best trial lens plus the over-refraction is recorded as the final lens prescription. If the over-refraction is greater than plus or minus 4 diopters, the vertex distance must be taken into account when calculating the final lens back vertex power. If the vision is not corrected adequately by a spherical lens, it is possible to order a front surface toric or a bitoric lens design. In most cases, it is best to order a spherical lens and reassess the visual performance at the first aftercare visit. Summary. The Rose K system for keratoconus is specifically designed for easy fitting. The extensive trial lens set provides a wide range of back optic zone radii and powers to meet the demands of fitting early, moderate, and advanced cases. The simplified ordering system and practical design features ensure a high success rate when fitting these challenging patients.